Hello everyone. In this video, I will be sharing medicinal and clinical pearls related to drug metal ion interactions. Specific agents or drug classes include fluoroquinolone and tetracycline antibiotics, anti-HIV integrase inhibitors, bisphosphonates, levothyroxine, omadacycline, baloxavir, marboxil. All these medications, for example, fluoroquinolone and tetracycline antibiotics, anti-HIV integrase inhibitors, need to avoid co-administrations with polyvalent metal cations containing supplements, antacid, and dairy products. As you can see, based on their general chemical structure, fluoroquinolone, tetracycline, integrase inhibitors. Within all these drug molecules, there is a metal chelation motif, which is highlighted in blue. All this metal chelation motif here will interact with metal ions, chelates with metal ions. For example, iron, calcium, magnesium, and aluminum. Subsequently, this drug metal chelation complex can lead to decreased solubility, absorption, and oral bioavailability. Therefore, for patients, if they need to take all this medication together, for example, fluoroquinolone or tetracycline or integrase inhibitors with metal supplements, either avoid co-administration or space them out. For example, administer these medications 2 hours before or 6 hours after some metal containing antacid and supplements. Similar to fluoroquinolones, tetracycline, HIV integrase inhibitors, additional medications with metal chelation motifs include bisphosphonates, levothyroxine, baloxavir, marboxil. As you can see, based on this bisphosphonates agent class, there are 2 phosphonates motif, so therefore they call bisphosphonates derivatives. This class of medication is commonly used for the prevention and treatment for osteoporosis in postmenopausal women, along with some other approved indications. If we look at their general chemical structure, due to these 2 bisphosphonates, the physiochemical properties and the pharmacokinetic profiles of bisphosphonates, so these are hydrophilic drug molecules with low log p-values, for example, -0.5 to -3. This hydrophilic structure feature will lead to poor absorption in the guts, less than 1% for alendronates and rosindronates, limited cellular penetration, and low distribution. Also, this medication drug class contains this stable phosphor-carbon-phosphor bond coming in the middle linkage. Therefore, this class of medications are not metabolized because of this stable phosphor-carbon-phosphor bond. One thing I want to mention, when we talk about the drug metal ion interactions, so we talk about the oral medication with all these metal ion interactions. For some medication, for example, zoledronic acid, this is RV injectable medication. So therefore, in this case, This drug-drug interactions won't apply in this case. To enhance absorption, calcium supplements and any aluminum or magnesium containing antacid should be dosed separately. And if we look at some other medication, levothyroxine, omadacycline, they all have this metal chelation motif, as well as baloxavir, marboxil. So that's all the metal chelation motif. Now I'm going to highlight a few specific agents. Levothyroxine, brand name SYNTHROID. This medication was initially approved by the US FDA in 2002 and indicated for the treatment for hypothyroidism as a replacement therapy and pituitary thyrotropin stimulating hormone, TSH, also known as thyroid stimulating hormone suppression. This is a synthetic T4 form of endogenous thyroxine hormone. Gastric acidity favors levothyroxine absorption. The dosing and administration. Starting dose varies. For adult starting dosing, it's equal to or less than 1.6 microgram per kilogram per day, and then titrates the dose accordingly. This medication is taken orally once daily, preferably on an empty stomach, 30 minutes to 1 hour before breakfast. This medication carries a US box warning, not for the treatment for obesity or for weight loss. If you look at the drug chemistry, this is a synthetic form T4 because there are 4 iodines within the drug molecule, 2 iodine in outer ring and 2 iodine in inner ring. Molecular weight 776.87 gram per mole. Hydrogen bond acceptor 5. Hydrogen bond acceptor refers to the number of oxygen and nitrogens within the drug molecule. Hydrogen bond donor 4. Hydrogen bond donor refers to the number of hydroxy or the NH groups within the drug molecule. Log P 4.72. The higher log P, which means it's more lipophilic. Polar surface area 92.8 square angstrom. Mechanistically, T4 is converted to the active T3 form by deiodination in peripheral tissues to exert its physiological effects. Pharmacokinetically, absorption ranging from 40 to 80%, onset 3 to 5 days, protein binding more than 99%, metabolism T4, the drug molecule, to be converted to the active T3 form by removing 1 iodine from the outer ring. So that's the deiodination process. Or it will be metabolized to reverse T3. Reverse T3, that's removed by removing 1 iodine from the inner ring. Or T2 metabolites. Tmax 2 to 4 hours. Half-life 6 to 7 days. Excretion in the feces about 20%, in the urine, that's the major excretion route. Drug-drug interactions, phosphate binders, and metal supplements. For example, calcium carbonates, iron sulfates, sevelamer, lanthanum, bile acid sequestrations, and ion exchange resins may bind to levothyroxine, and therefore this would lower its absorption. So therefore, for patients, if they need to take all this medication together, phosphate binders, metal supplements, or bile acid sequestrations with levothyroxine, so make sure all these medications need to be spaced out at least 4 hours apart. For patients, if they take a PPI, that's the proton pump inhibitors, sucralfates, or antacid, may lower levothyroxine absorption. As mentioned earlier, gastric acidity favors levothyroxine absorption. So therefore, patients, if they take a PPI, sucralfates, or antacid, because this would increase the pH value, so therefore this would lower levothyroxine absorption. Beta blockers and glucocorticoids may decrease the conversion from T4 to T3. Adverse effects primarily from hyperthyroidism due to therapeutic overdose. Omadacycline, brand name NUZYRA. This medication was initially approved by the US FDA on October 3, 2018, and currently indicated to treat adult patients with community-acquired bacterial pneumonia and acute bacterial skin structure and skin infections due to susceptible microorganisms. This is a novel aminomethylcycline with the 9-neopentyl-aminomethyl side chain at the 9 position. This is a semi-synthetic derivative of the tetracycline antibiotic class. This medication is available both oral as 150 mg tablets as well as 100 mg as a lyophilized powder for RV use. So therefore, this medication is available both orally and RV dosing. Recommended dosage for RV dosing starting 200 mg once or 100 mg twice on day 1, then 100 mg once daily. For oral dosing, starting 300 mg twice on day 1 or 450 mg once daily on days 1 and 2, then 300 mg once daily for a total of 7 to 14 days. If we look at the drug chemistry, as mentioned, this is a member of a tetracycline antibiotic class. Molecular weight is 556.7 gram per mole. Hydrogen bond acceptor 11, hydrogen bond donor 7, log P 1.85, polar surface area 177 square angstrom. Mechanistically, this medication inhibits protein synthesis via binding to the bacterial 30S ribosome subunits. Pharmacokinetically, protein binding about 20%, oral bioavailability 34.5%, Tmax 2.5 hours, but for the RV dosing, Tmax is about 0.6 hours. Half-life for oral dosing is ranging from 13.5 to 16.8 hours. For RV dosing, half-life is about 16 hours. Volume of distribution at steady states for oral dosing is 440 liter. For RV dosing is 190 liter. Metabolism. This medication is not metabolized. Therefore, we don't expect much drug-drug interactions for patients to take other CYP inducer, for example, or inhibitors. Excretion. Feces 81.1%, in the urine 14.4%, but for the RV dosing in the urine, so that's about 27%. Drug-drug interactions. Antacid containing aluminum, calcium, or magnesium, bismuth, subsalicylates, and iron containing preparations decrease NUZYRA absorption, separate their dosing. Again, because omadacycline have this metal chelation motifs, so therefore for patients, if they take antacids containing all these metal supplements, so have to make sure they space out these medications. Tetracycline decrease plasma prothrombin activity, may require lower the anticoagulant dosage when taken concomitantly with NUZYRA. The most common adverse effects, at least 2%, nausea, vomiting, infusion site reactions, hypertension, headache, diarrhea, insomnia, constipation. Baloxavir, marboxil, brand name XOFLUZA. This medication was approved by the US FDA on October 24, 2018, and indicated for the treatment for acute uncomplicated influenza A or B, and for post-exposure prophylaxis of influenza in patients aged 5 years and older. This is a prodrug to form the active baloxavir acid. This represents the first in-class medication. If you look at the drug molecule, because this is a side chain carbamate ether, so therefore this is a prodrug. Later will be metabolized, hydrolyzed to form this baloxavir acid. This medication is available as 40 mg, 80 mg tablets, as well as 40 mg per 20 milliliter oral suspension. Recommended dosage. This is a single oral dosing regimen in patients aged 5 years and older. Tablets based on the patient body weights from 20 to less than 80 kg. The dosing is 40 mg orally, with or without food. For patient weights greater than or equal to 80 kg, the oral dosing is 80 mg. For oral suspension dosage forms, for patient body weights less than 20 kg, the oral dosing is based on the weights 2 mg per kilogram. For patient weights from 20 to less than 80 kg, the oral dosing is 40 mg, 20 milliliter. For patients' body weights greater than or equal to 80 kg, the oral dosing is 80 mg, 40 milliliter. Again, if we look at the drug chemistry, so the molecular weight for this medication is 571.55 gram per mole. Hydrogen bond acceptor 10, hydrogen bond donor 0, log P 3.32, polar surface area 123 square angstrom. Mechanistically, this medication works as an influenza virus polymerase acidic endonuclease inhibitor. Pharmacokinetically, Tmax about 4 hours, half-life 79.1 hours, protein binding ranging from 92.9 to 93.9%, volume of distribution 1,180 liter. Metabolism. This medication is mainly metabolized by the phase 2 conjugation metabolism by this UGT1A3, that's uridine 5' diphosphorabonucleosil transferase YA3. CYP3A4 also plays a minor role in metabolism. Excretion in the feces 80.1%, in the urine 14.7%, but 3.3% as active metabolites. So the active metabolites, that's the baloxavir acid. So with the hydrolyzed and this acid there. Drug-drug interactions, dairy products, calcium-fortified beverages, polyvalent cation-containing laxatives, anti-acid, or oral supplements. Avoid concomitant use. Live attenuated influenza vaccines may be affected by XOFLUZA. Contraindications: hypersensitivity history to baloxavir, marboxil, or any ingredients within the drug molecule, within the drug products. The most common adverse effects, at least 1%, diarrhea, bronchitis, nausea, sinusitis, headache. This is all the key reference which I have used to prepare for today's video. Specific drug prescribing information associated with the fluoroquinolone and tetracycline antibiotics, anti-HIV integrase inhibitors, and bisphosphonates drug class. All the specific information for the specific agents we just talked about today, levothyroxine, omadacycline, baloxavir, marboxil, all these are based on the latest version of prescribing information documents. Finally, I want to thank you all so much for watching. If you enjoyed the video, please consider subscribing for future medication video updates. As always, keep learning and elevating. Thank you so much.